Last year I was invited to attend an OhioHealth community forum, and I quickly accepted the invitation to hear what Columbus Rotarian David Blom and his staff had to say. One segment of that forum that really stayed with me was presented by our speaker today, Dr. Bruce Vanderhoff. Dr. Vanderhoff is Senior Vice President and Chief Medical Officer at OhioHealth. He's responsible for leading system-wide initiatives to improve quality and patient safety, advancing OhioHealth's physician leadership program, medical education, and the OhioHealth Research and Innovation Institute, and also assuring organizational alignment leading to clinical integration and value delivery. And before that, he served, 12 years as
sort of head of medical education.
Head of medical education, which means he was in charge of all the residents. So we had some discussions about that this morning. However, it was OhioHealth's effort to keep care local and their concept of regional partnerships that really spoke to me when I was at the forum last year. And perhaps that was because I had a family member at the time who was using their services and was able to drive 20 minutes from her house instead of jump in the car and drive over an hour and a half to Columbus. Regardless for my reasons why his speech stuck with me, I talked to Brian Dean in the program committee and thought that you should hear it as well. So without further ado, Dr. Bruce Vanderhoff.
Well, good afternoon. It's a real pleasure to be with you here. You know, healthcare is one of those topics that's actually relatively easy to speak to an audience about because it's very personal. It affects all of us in a variety of ways. It affects each and every one of us as patients. We all, in one way or another, at one time or another, are patients. It also affects us as family members and friends, as we journey with our loved ones and friends through various aspects of healthcare. And it affects each of us in the workplace. It affects us as leaders, managers, business people, because healthcare and healthcare costs, as well as its impact on the wellness or lack thereof of our associates and employees, really does impact the success of our businesses. And so as I was thinking about this and thinking about that talk that we gave a number of months ago, I thought about, well, what are those headlines that really matter to people in our community? And really, when you look at what people talk about when they talk about healthcare, they talk about three things. They talk about quality, they talk about cost, and they talk about accessibility. Now, when it comes to quality, I'm not going to spend a lot of time today talking about that. And the reason is because we're here in Columbus. And Columbus is blessed with an incredibly high degree of quality in healthcare. Now, that doesn't mean that I think we don't have areas where we need to continue to make strides. We do. One area we know we need to make strides is in the area of infant mortality. We have an infant mortality rate in this community that is shameful, but really when we dig down deep into it, it has much more to do with the social determinants of health and what we're doing about those than it does about the health care we give those little ones when they hit the healthcare system. Our quality in this community has been so good in part because it is in the nature of Columbus to be collaborative. And all of the health systems in this town have worked together through our quality collaborative to raise all of our quality together. And as a result of that, we've enjoyed multiple visits from the Secretary of Health and Human Services and other dignitaries who've come in to recognize the level of healthcare quality that is resident in our community. As the medical leader of OhioHealth, I'm particularly proud of our health system. Ours is one that is recognized nationally for our quality. Anywhere I go working with my colleagues, that's recognized and called out. And quite simply, our system is one that has, in modern healthcare, been recognized more than any other for being among the top 5 large health systems. So we've achieved a lot in that area, as have our colleague organizations. But the issue of cost is another story. When you look at the cost of healthcare, it is one of the major elements of our economy. It accounts for 17% of GDP. And if you look at that graph that's up there, if you could see it, trust me when I tell you that most of the items there are directly impacted by decisions that physicians make. By the physician's pen, back in the day when we used pens, now we push on keyboards, but it is decisions that physicians make in partnership with patients that drive an awful lot of that cost. Now, the good news is that 17%, which, by the way, compares internationally, the next closest nation is Sweden, and their percent of GDP is 12%. But that 17% is actually an improvement. The year before, it was 18%. And that's the first time in a very long time that the steady year in, year out rise in the cost of healthcare and as a percentage of GDP actually reversed. Now, the question, is why? I'm going to tell you it had actually very little to do with legislation. Very little to do, for example, with federal legislation, most of which was really focused on expanding access to healthcare. It was market forces. It has been the demands and needs of the business community to say, hey, I just cannot continue to manage with year in, year out increases at the pace I've seen, and we need to do something about it. That has driven most of the forces that led to that 1% improvement. Now, achieving continued improvement in the cost of healthcare is going to be a challenge that all of us have to contribute to at all of the levels we interface with healthcare. As patients, we've got to take a different approach than we have historically taken to our healthcare. And I'm going to unpack that a little bit. As employers, as managers of businesses, we've got to think differently about healthcare and think about the value of workplace wellness rather than thinking purely about the cost that's associated with our workers' compensation. And then on a larger scale, as decision makers, we have to either help decision makers or ourselves as decision makers for large numbers of people be thinking about healthcare in a different way. And again, I'll unpack that a little bit more. So I think a lot of it begins with how we think about and deal with issues related to chronic illness. Healthcare has, dating all the way back to the time of Hippocrates, been focused primarily on the treatment of illness and injury. And we've become incredibly good at it. All you have to do is look at what we can do today for the treatment of patients with heart attack, with stroke, with major trauma. And I will tell you, as a physician who's witnessed it, in the course of one generation, we have advanced those skills to prodigious heights. It is absolutely amazing what we can do. But I think more and more as we're thinking about these issues of the cost of healthcare, we're more and more aware that that's only part of the equation. That our healthcare has to be as much about health and wellness as it is about treating illness and injury. That the old adage, an ounce of prevention is worth a pound of cure, makes a lot of sense. It rings true. But the challenge in dealing with that is that we have to recognize some things. First of all, 7 out of 10 people who hit the healthcare system are having expenditures made related not to treating those remarkable ability to treat acute illness and injury, but rather to dealing with the ravages of chronic disease. So it's chronic disease that drives most of the cost. Conditions like diabetes, hypertension, hyperlipidemia, the scourge in our society of obesity, those are the things that are driving more than 70 cents out of every dollar. The second piece that we have to recognize is it compels us as healthcare consumers to think and act differently about our healthcare. We have to become much more engaged around issues of health and wellness. And that is where I think all of us as either business people or community leaders come in, because people are not going to get it done by themselves. We've tried that. It just doesn't work. Shakespeare had a line that I think is particularly apt here. And Shakespeare said, "Our bodies are our gardens, but our wills are our gardeners." The simple fact of the matter is that we have to focus on 4 things in our lives very intently if we're going to deal with that 70 cents out of every dollar. The first is our diet. And in the case of Americans, it's mostly eating too much. The second is cigarette smoking. The third is excessive alcohol consumption. And the fourth is exercise, or in our cases, too often, not exercising. Now, the challenge is dealing with all of those require us to make fundamental changes in how we lead our lives and how we do things. But we were just referencing the fact that we're all crazy busy. We have tremendous demands upon our time. And I will tell you, I know what happens to me when my schedule gets crazy, when I start at 6:30 in the morning and I walk through the door at 8:30 at night. What do I sacrifice? I sacrifice exercising, and I eat the wrong things. And I eat too much of them. That's typical for all of us. But as a large employer and as a large healthcare provider, you know, OhioHealth now employs almost 30,000 people, and that's grown considerably in the last 2 years. And we are in almost 47 counties, either ourselves or with our affiliates, the dominant or major healthcare provider in those counties. We have a lot of experience living on both sides of the equation. And through our own health insurance program called OhioHealth, the program my family and I have, we've learned a thing or two about this equation and how we can help people succeed on this journey. And OhioHealthy, our approach, begins with plan design. And our plan has front-end deductibles that give me and my family a stake in the first dollar spent. And we do that not because we're cheap and not because we're being punitive. We do that because that's necessary to help us engage as informed healthcare consumers, helping us learn enough about the cost of healthcare that we're at least a fraction as knowledgeable about that as we are about the cost of butter in the grocery store. But we go further. We provide our associates with real incentives for doing the things that help them stay well. So those incentives include things like incentives for not smoking, incentives to know our numbers, to know blood pressure, cholesterol, blood sugar, and incentives to exercise, knowing that for every pedometer step I log, at the end of the year, I can earn real money back in my pocket. But we go further. Beyond those incentives, we provide our associates with real help along the journey. One of those helps are medications for many chronic conditions that we make available free or at substantially reduced cost. Another help is that we provide care managers so that people with common but nevertheless less complex conditions like diabetes, and asthma have the benefit of someone who can help lead them through what their doctor is actually asking them to do. And finally, in the form of education and coaching, so that, for example, I can have some guidance about how this time to succeed at quitting the smoking habit, or what the exercise regimen I really should be following is. And the net result of this kind of comprehensive approach to health and wellness in our workplace has been staggering. In the last couple of years, we've collectively lost 50,000 pounds. Not surprisingly, fewer of us are now requiring blood pressure medication, fewer of us are going to the emergency room for the treatment of our asthma, and our diabetic costs the last 2 plan years dropped 13% and 20% respectively. And so at a time when most employers have had no choice but to pass on to their associates increases in the cost of their health plan, we were able to lower ours and maintain those reductions over a period of years. But, you know, to do that, to take that kind of comprehensive approach to how we help people with the challenge of being better gardeners, we need physicians. And when we're talking about health and wellness, we especially need primary care physicians. And by any account, we have not been producing enough of those people over the course of the last decade or so. And so our approach to that challenge has been twofold. First, we've focused on the model of primary care. Medical students, residents, practicing physicians have all told us the same thing. The old model isn't working for them, and it's not working for their patients. They feel that they're on a treadmill, moving from room to room, treating problem after problem, and they don't have the time or mental energy to lift up and think about the health and wellness that they were trained to deliver. And so we're taking a model that I'm sure you've heard many names for it. One of them is the patient-centered medical home, a team-based model of care in which the primary care physician acts more as the team leader, the quarterback of a team of providers, freeing that primary care physician to focus on the more serious aspects of illness in the practice, as well as managing the comprehensive wellness of the population that they are privileged to take care of. Gets them off that treadmill. The second prong to our approach has been to expand the pipeline. And I know that my good friend and colleague Ken Johnson was here to share a little bit with you about that project. We have partnered in an historic way, a way that to our knowledge has not occurred before, with Ohio University to bring an entire medical school campus to our community dedicated to training primary care physicians to practice here in the communities that we, OhioHealth, serve. And we couldn't be happier with the early success. First inaugural class began back in August. They're almost done with their first year. We had 50 medical students in that class. I'm sure Ken shared that with you. 48 were from the state of Ohio. That's very unusual. Most of our medical schools here in Ohio, in fact, are made up of a minority of Ohioans. And so we have a school that has proven to be one of the nation's leaders in training people to go on to careers in primary care, who is now bringing a campus here that is training the sons and daughters of our state to practice primary care here in our state. And OhioHealth is helping along the way with instruction and providing postgraduate residency opportunities for those medical students. So very exciting, and we feel very good about that progress. But once you have this, once you have an ability to bring the right primary care resources into communities, you've got the right model for how to do that, you've got an approach that is proven in terms of comprehensive wellness. How do you deliver that to a region? And for us, that is where our network comes in. And you heard reference to the philosophy that guides that network. Now, if you look at this map that shows the counties where our hospitals, our healthcare system, and our affiliates are the lead providers. It's the area that we consider our area of responsibility. And for every hospital that you see up there, you see many other facilities, many more facilities of other types. Things like freestanding emergency rooms, things like health centers, etc. And what underpins that approach, and what makes our approach to that very different than the approach that other organizations take, is our philosophy, which is that people need health care that is able to deliver the right care at the right time and the right place. And that does not mean driving people to the front door of Riverside Methodist. Rather, that means our taking health care to their front door. Because when people are sick, they want to be close to home. And health care needs to be delivered close to home if people are going to take maximal advantage of it. And so our entire system is organized along that line. And so rather than investing in continuing to expand the platform and the size of our Central Ohio tertiary care centers, yes, we've invested in modernizing and updating them so that the new kinds of care that we're delivering can be delivered there. But the added capacity in our system has not needed to be there, it's needed to be in the community. And let me give you three examples. Let me give you three examples of how that plays out. The first is in the realm of cardiology. What we've done is organize all of our cardiologists, cardiovascular surgeons, all of the physician providers in our system into one large comprehensive practice, and then organized their care in a way that brings as much of it as close to where the patients live and work as possible. That means that today, the vast majority of our patients receiving cardiovascular care are receiving advanced diagnostic services and even many interventions right there in the community in which they live and work. And only when they need the cutting edge, advanced capabilities that in some cases are only available in our region at Riverside, do we ship them using our transfer center to Riverside Methodist for that care. Another area is in the neurosciences. Riverside Methodist, in the neuroscience center there, is the largest provider of advanced neuroscience care in a multi-state region. It's actually one of the, by volume, third largest in the country. We could very easily look at that and say, well, you know, if you have a neurologic issue, that's the place to go, isn't it? Well, yes, but the right thing to do for the communities we serve is to expand that access out to where people live and work. And so through a variety of mechanisms, including telemedicine, we're now delivering those services to those communities. And here's the kind of impact it has. Now, when patients have strokes, because of our stroke telemedicine capability, the vast majority of them are able to be examined in concert with one of those advanced treatment neuroscientists in the emergency room, in the community where they live, and treated, stay at that hospital until their treatment is done, and go home. Those individuals who need the kind of advanced intervention that we can only deliver at Riverside get put onto an ambulance or a helicopter and shipped directly to the lab. And the lab is ready and waiting for them when they arrive. That kind of capability has resulted in more patients not only staying in those communities where they live, but the outcomes of their care in a field where minutes mean brain. And so the outcomes of care have improved as a result of this model, this philosophy we have of delivering care when and where people live and work. And lastly, oncology. And so as we looked around, we recognized that one of the problems in oncology is that too often healthcare systems, we were thinking of oncology in the way it was practiced yesterday, which was in the hospital. You were sick, you needed chemotherapy, you came into the hospital and you got your chemotherapy. It was certainly that way when I was training. Today, that's not the way it's practiced. Chemotherapy is almost exclusively delivered in the outpatient environment. Most cancer care does not happen in the hospital. And so through our affiliation with MD Anderson, and as the region's only MD Anderson Cancer Network partner, we're able to take the expertise of MD Anderson, assuring that our physicians have been certified and are practicing the protocols of MD Anderson, and deliver that care in a distributed way throughout the communities where people live. Now, achieving all of this is a great thing, but the foundation of how we achieve that is really a foundation of engagement. We have to be thinking about the patient first. This is really not about the doctor being able to see you. It's really the patient being ready to see the doctor. And so we have had to undergo a fundamental philosophic change in how we think about the care that we deliver. It's also about engaging physicians, engaging all the healthcare providers, the nurses, the pharmacists. We have to better understand how delivering the care that they've been trained to deliver should be done, not relying on yesteryear's model, but as I described with those primary care physicians and the cardiologists, being willing to change the model to be more responsive to what the patients need. And it requires engagement from us as community leaders, business owners, managers, and employers, because we've got to be willing to think as much about health and wellness as we do about dealing with illness and injury. And it means thinking about quality and the patient in a new way. We've got to be able to extend our traditional model of thinking about quality to remembering that quality begins with access. We have to be able to assure that there's access to providers and that there's access to capabilities in all of our communities. And finally, we have to think about the incentives. We as patients need a new set of incentives, not the incentives to go and utilize more and more and more services, but incentives to take the steps that are necessary to stay well. You know, one of the things that drives me crazy is when I see these screening modalities. I just saw a commercial for one yesterday where they say for $100 and whatever you can come in and have all sorts of parts of your body scanned with an ultrasound and how wonderful and life-saving that will be. Well, you know what? The science doesn't say that. Actually, the science says that that's wrong. That what we're actually doing is finding a whole lot of problems that are not actually going to be a problem, putting people through a lot of turmoil, anxiety, etc., and that there are very clear screening guidelines that, by the way, all your primary care physicians are very well versed on. They all know them, and I know that for a fact because they're tested on them. And those are the things we ought to be doing, not the shotgun approach that does nothing but increase anxiety, complications, and drive up the cost of care. And there need to be new incentives for health systems so that health systems and physicians are motivated to think about the outcome of your care, to think about how well we keep you, not how many widgets we produce. And then I think, lastly, we have to have a different set of incentives as a society where we're thinking about, you know, how are the little ones doing? How is it that we could have the capability of just doing incredible things for every patient who has a heart attack, a stroke, or major trauma here in Columbus, and yet we've got one of the worst infant mortality rates in the country. Now, I want to close by leaving you with a quote. And the quote comes from a man who was well known for his many quotes, Benjamin Franklin. And the reason I want to leave you with a Franklin quote is that he founded the University of Pennsylvania, which is where I went to medical school. And Franklin had this to say about physicians. He said, "The best physicians give the least medicines. One of the things that I am most proud of about being the Chief Medical Officer of OhioHealth is that I am confident that I work for and am a leader in a health system that gets that and that is working very hard to assure that our physicians are, by Franklin's definition, truly the best physicians. So thank you, and I'm happy to entertain any questions that anyone may have. I must have, oh, okay, great. Yeah.
Could you draw the similarities and the distinctions between the new medical campus that you referenced here in Columbus versus those that are OU Athens?
Yes, absolutely. So one of the things that we were very mindful of is that we did not want to create a tale of two cities with those campuses. We wanted the medical students to have an integrated experience and to have the same quality of medical education. But we also recognized that Dublin represented for us really the first time to build it from the ground up and to create a model laboratory for how we would train young people to pursue a career in primary care in a way that had them hitting the ground running when they reached residency. And then to take those lessons and translate them back to the Athens campus. So I would say that 75 to 80% of what those folks experience at the two campuses are the same. What's unique about the Dublin campus is this. On the Dublin campus, we have a group of faculty who have been selected from the Central Ohio medical community, who have proven that they are not only good primary care physicians, but that they are also forward-thinking, that they are people who have had experience in this new model of care. They are people who have demonstrated that they know how to make the shift to health and wellness and that they get this team-based model. My simple way of describing it is I think that these students in Dublin have the opportunity to have a curriculum that prepares them identically to the curriculum in Athens, but have a clinical experience that uniquely prepares them for primary care of tomorrow. And what we learn from that will translate quickly back to Athens. Athens, by the way, as a campus, has a focus that I think is also important, that may be a little bit more organized around a different breadth of candidate. The candidates for the Dublin campus are actually very carefully selected specifically for their interest in primary care in Central Ohio.
60 Minutes did a recent story about immunotherapy as the fourth alternative to cancer.
Yes.
As the Chief Medical Officer of OhioHealth, what has your directive been to your researchers?
Thank you for bringing that up, because it's actually a topic that is very near and dear to my heart. I think that genomic therapy, personalized medicine, is not only the wave of the future, it is the future of how medicine is going to be practiced. Our research, first of all, is expanding dramatically in this area, so much so that I've actually identified a single physician leader who is going to be responsible for our research enterprise. We've seen the number of trials and so forth going on inside OhioHealth more than double in the course of the past couple of years. And this had a lot to do with our affiliation with MD Anderson, because we recognized that we needed the horsepower of the nation's leader in advanced cancer therapy to help us along that journey. And it's been very fruitful. For example, today we're actively using this personalized medicine, this genomic identification in a large number of the cancers that we treat. And our cancer providers are, through that MD Anderson affiliation, very much on the cutting edge of some of these new developments. The 60 Minutes that was highlighting some of this recently spent a lot of their time focused on the use of the polio vaccine, essentially to rev up the immune system. And anyone who read that study would have, as I was, be absolutely astonished at the impact of it. Now, there's a lot for us to learn, because we have to learn how to focus that. We have to learn whether it is something unique about the immunogenicity of the polio vaccine or if there are other vaccines, but there are a host of opportunities there. But to your question, what we've done is we've doubled down on our research enterprise, which has been growing by leaps and bounds. You know, when I first stepped into this role, our research enterprise was nice, but the pace at which it has grown over the course of the past several years has just been astonishing. But I think it's what we need to do. We need to invest in that kind of research for our community. Yes?
I don't know about the demand for students to take up primary care positions. I've been given to understand the compensation is not commensurate to all the debts they accumulate during their education.
Yes, yeah. So you're absolutely right. So the question really relates to how can we expect more people to pursue careers in family medicine and other primary care disciplines if we're not doing something to help them with the debt? Because you're asking people to go into the least well-compensated specialties with still the same large debt that other people are entering into practice with. And so we've taken a number of steps in that direction. Our program first begins with creating opportunities, particularly for people from underserved backgrounds, to participate in a scholarship program that begins during medical school. Beyond that, we have developed loan repayment programs that begin when a student goes from Ohio University into one of our residency programs in primary care, and then continues on when they move into primary care practice inside of OhioHealth, where we have then even further loan forgiveness programs, all cobbled together. If a student were to make a commitment coming out of Ohio University to primary care with OhioHealth, the vast majority of that debt will be forgiven over time. In other words, we will pay the bill. Yes.
What's been the impact of the Affordable Care Act on your health system?
Well, you know, it's been very interesting, and that's why I referenced that at the beginning. I think the Affordable Care Act primarily has been legislation that has expanded access. So what we've seen are an increased number of people who are seeking care inside of our organization. We've really not seen it have much of an impact on the structure or the nature of insurance. Most of the factors that have affected the changes that we're seeing in the payment model, again, are being driven by business and by the insurance industry itself. So, yes?
Is there a compensation awarded to medical schools to take foreign students into medical school rather than the United States citizens?
No, not to my knowledge, not in the way that we might think. But let me explain what happens in medical schools that has created a challenge for our communities. Many medical schools are looking at the people they bring into the school primarily in terms of the test scores that they take. And by the way, all these folks have very high test scores, but they're looking and saying, well, I want the people who have the very highest scores, then I want the people who have done a list of things that look particularly extraordinary and have come to me from a university that will bring greater accolades in the academic environment to my school. And so you find medical schools that may be bringing in a very small number of people from the state of Ohio. In one case, I'm aware of a situation in which there's one state out west that has more people from that state in one of our medical schools here in Ohio by far than it has students from Ohio. And all we've done at OU is say, look, we want the best and the brightest, but we want to give a little special oomph to the candidate who comes from Ohio. And if you've got roots in Ohio, and you have, and OU has over the years figured this out quite scientifically, if you have a profile that means that you are far more likely to pursue a career in primary care, we're going to give you an advantage. And we aren't really fixated on whether you went to your undergraduate training at Harvard or UCSD or we want to see that you've got strong test scores, you did well in college, and oh, by the way, you're really going to be pursuing your career in primary care and staying in Ohio. Do I have time for one more? No?
Yeah, one
Okay,
more?
okay.
That's fine.
Yes?
Just looking for your opinion here. When you talk about not getting enough physicians going into primary care or physicians, period, we've seen a lot of
Yes.
You have Obamacare providing insurance where the person who gets that insurance can't find a physician because they don't take that insurance.
Right, right.
So this is one big mess. So how do you propose that you're going to get more physicians not working for the hospital going into primary care if they can't afford to be a physicist because of debt or because they're not going to get paid by the insurance from Obamacare? And
But you're,
it's a
so
big
you're
mess.
asking,
So what do you want to, how can you speak about that?
yeah, you're asking a great question. And as a healthcare organization that is very committed to our communities and therefore pays very close attention to primary care, it's what we've struggled with. Here's the approach that we've taken. Now, as a healthcare system, there's only so much we can do. But the things that we've identified that we can do are, first, I've described increasing the pipeline. So we're doing things that are increasing the pipeline. Secondly, focusing on making it possible for young people to go into primary care and succeed, to go into it in a way where they actually can pay the bills, keep their family dressed and, get their own kids off to college, et cetera. And here's how we've done it. I've talked about the loan debt forgiveness that we provide. Secondly, we actually do provide for those who are in private practices and seem to be making it. We do provide startup assistance in our communities for those practices to bring in a new person. But more and more, the primary care physicians are saying, look, I want to work for somebody. I want to be able to collect a paycheck. And so we are employing them in these communities. In fact, most of the growth of primary care in our system has been through employment. And that has been very well received by the medical students and residents who are choosing careers in primary care. When we've surveyed them, that's what the young people have told us they want. They don't want to go into an entrepreneurial situation. They want to go to work for somebody so they can focus on being a doctor. And more, they want to go to work for us. And I think in part it's because we're not only addressing making sure they have a living wage, but we're also providing them with an updated model for how to deliver that care that resonates with them. Well, thank you very much. I appreciate the opportunity.
Doctor, thank you for coming and speaking to us.
My
And
pleasure.
here's a gift from us from Argo and Laney.
Thank you so
Thank
much.
you. That was very interesting.
Thank you.
Appreciate it.
Thank you.
Join us next week to hear Jim Bache speak about new technology provides energy independence. Thank you.